Good afternoon. My name is Terry Lake. I'm the CEO of the BC Care Providers and Engage BC. And I'd like to welcome you here today for day one of our virtual conference 2021 and this very important plenary panel discussion on what went right and what went wrong, seniors care and COVID-19. I'd also like to thank our sponsors for this session, Extendicare and SGP Purchasing. Well, to date, most jurisdictions around the world, including Canada, have been affected to some degree by COVID-19, and particularly hard hit was the long-term care sector. Well, of course, we're dealing with many frail and people with multiple chronic conditions, making this an extremely challenging environment. And while BC has fared fairly well, particularly in the first wave versus other jurisdictions like Ontario and Quebec. We certainly have seen that over half the deaths from COVID have been in long-term care. To protect seniors in care here in BC, various measures were taken, like using the federal Safe Restart funds to put money into the Equip Care program for very important infection prevention and control practices. We had the single site order facilitating safer visitations. Of course, increasing human health resources through the HCAP program. And the most important thing, of course, prioritizing this population for vaccinations, which has made such a significant difference in terms of outbreaks and the suffering due to COVID. But despite these, as I mentioned, we've seen more seniors in care pass away from COVID than in other parts of our population. So this panel will look at some of the factors that may have played a role there, including the level of community transmission and also challenges and concerns around PPE, about health human resource challenges and how those dramatically were spotlighted during the pandemic, the physical design and layout of care homes, including particularly in older parts of Canada, the use of multi-bed rooms. We'll look at single site orders and how they might have mitigated the spread of COVID-19 and whether they're still necessary or in fact may be impairing our ability to manage human resources to provide optimum care. We'll look at the question of vaccinations and rapid testing. We'll look at visitation restrictions and whether or not we got the right balance there. And specific populations like those suffering from dementia and those from marginalized communities that were adversely affected. While the focus is on long-term care, we'll also look at other parts of the continuing care continuum, including home care and independent living and some of the unique challenges to those environments. And with that, I'm really happy to introduce our panel today. We have a very distinguished panel, including Dr. Bob Bell from Ontario, Joanne Tait from Vancouver Coastal Health, and our own Debra Hauptman from the Langley Care Society. First, I'd like to introduce Dr. Bob Bell, who is currently a professor of surgery at the University of Toronto. Dr. Bell is an internationally recognized orthopedic surgeon, clinician scientist, and educator who has chaired expert panels that provided advice on emergency room overcrowding, critical care capacity, vision care and eye surgery, and neurosurgical care in Ontario. Dr. Bell would become CEO of the University Health Network in the Toronto region. And I know Bob best from his role as Deputy Minister of Health to the Minister, Dr. Eric Hoskins, for 4 years. A number of accomplishments there, Bob. Probably the biggest was working for another physician with Dr. Hoskins, but we'll get into some of that discussion. So we're really happy to have you here with us. Secondly, I'd like to introduce Joanne Tait, the Executive Director of Regional Long-Term Care, Assisted Living, and Supported Housing for Vancouver Coastal Health. Joanne is a strong and visionary leader, and she's one who favors calm and collaborative approaches, something we've appreciated about Joanne in our regular meetings. She has extensive leadership experience in seniors care across the continuum of acute care, tertiary mental health, rehabilitation, palliative care, long-term care, and assisted living. As the director for Vancouver Coastal Emergency Operations Center for Long-Term Care and Assisted Living during the pandemic, she has supported the creation of resources and coordinated responses for the outbreak, and we're really thankful for Joanne's leadership. And finally, I'd like to introduce Debra Hauptman. Debra has been CEO of Langley Care Society for the past 12 years. And Debra, we know that's coming to a denouement soon, and we just can't thank you enough for all of your service to our sector. Um, Debra is absolutely passionate about seniors care. She was appointed to the Township of Langley Seniors Advisory Committee to assist the municipality to achieve its age-friendly community designation. She's an Eden Associate and introduced the Eden philosophy of care to Langley Lodge in 2017. She's the chair of our quality, was the chair of our quality framework committee, now chairs our priorities and policy committee. Debra is a registered psychiatric nurse graduating from BCIT and has an MBA from SFU. And again, we're really thankful to have Debra as part of our team. So with that, I want to turn it over to the panel for some opening remarks. We'll start with Bob, then go over to Joanne, and then Debra. Then we'll come back for a Q&A. So over to you, Bob.
Thanks, Terry, and it's a pleasure to be with you here today. I think any discussion of the experience of long-term care during this COVID-19 pandemic needs to start by recognizing the suffering, the trauma, some cases, the tragedy that's been suffered by residents and their families during the course of this pandemic. Not only the illness, not only the concern about not being able to visit loved ones in long-term care homes that have often been locked down, especially perhaps in Ontario, but also the anxiety of residents who've been essentially inside their rooms for such long periods of time. I think when it comes to the question of what's gone right, what's gone wrong, I think we have to recognize the importance of careful analysis of the factors that led to the negative experiences, especially in many parts of the long-term care setting. And Terry, you started off by mentioning some of those, certainly in terms of the risk of infection in a long-term care facility. Probably the community prevalence of the virus was one of the major factors that led to the disease. We know it was brought into long-term care homes. In the early stage of the pandemic, the fact that most resources in Canada, certainly in Ontario, were focused in our acute care hospital system rather than being used to protect residents and staff in long-term care. The levels of staffing that were available to residents in homes have been a chronic problem, certainly in Ontario. And one of the important correlates for long-term care homes that suffered mortality and spread of infection was the fact that staffing became inaccessible during the course of these outbreaks in homes. Staff were, of course, quarantined, they were isolated, in many cases sick themselves. And it's understandable they couldn't come to work, but certainly that led to tremendous strain on residents. And finally, the issue of multi-resident rooms, Terry, that you've already mentioned. I can talk further about that in Ontario, but certainly we have 32,000 beds in long-term care of our 78,000 Ontario beds that are in homes that are older homes built in the 70s, 80s, and 90s that have multi-resident rooms, 3 to 4 people literally sharing air. These features, as well as the ownership model that saw private homes being mainly congregated in these older homes, were certainly some of the features that we should likely talk about today. So thank you for the invitation, Terry, and I'm looking forward to the discussion.
Thanks, Bob. Now over to Joanne.
Great, thanks, Terry. And one of the things I was reflecting on was the firsts, how we tend to spend a lot of our lives celebrating firsts, right? Our first words, our first steps, some of us even our first loves. But when our health authority was faced with the first resident death and first outbreak in the country, there was no celebration. And for us, it really catapulted everything that we thought we knew about managing outbreaks through influenza. It brought forward everything that we had learned through previous outbreaks and SARS in this country. And it felt like that very first month we were scrambling. And I echo what Dr. Bell was saying in terms of our focus had been on protecting our most precious acute care services and our ICUs. We were focused on decanting as many people, moving them out of hospitals and into long-term care for that first part of 2020. And then once March hit, our long-term care sector wasn't prepared. We were not ready. And so in that massive scramble, and I was at the helm of trying to support our long-term care assisted living sector and trying to bring everyone together amidst the fear, the concerns for themselves, and leaders trying to make the right decisions in terms of what needs to happen within their homes to protect all of our vulnerable seniors and their staff. It was absolutely bedlam. I don't know if I was volunteered or told. It seems like 2020 was a bit of a blur. In March, I think Vancouver Coastal took risks, and the risks did pay off in the end. We did put in single site orders before the province had gone ahead, and I know that that's not without significant pain and concern, and a lot of that we're still working through is still untangling all of that. But we needed to take prompt action immediately. We also developed the first rapid response team, which later became just an awareness of the amount of resources that our long-term care homes are in significant need. And certainly through an outbreak, the amount of resources that are required can be way above what any of our homes are certainly staffed with these days. And while there is a lot to be desired in terms of how things started, the what went right for me was that I was able to see and support leaders throughout our sector who leaned in. They didn't lean away. They put their home, their staff, their residents and families first and foremost. That set a culture which I think set our health authority in BC apart from the rest of the country. We had staff that would risk their lives coming into work every single day during outbreak. We had residents that literally tolerated the craziness that ensued for the last year. And we had families who, although were scared and frustrated, at the same time were incredibly grateful for the lives of our staff and our leaders who are coming into work into situations that put themselves at risk prior to vaccine even being out and developed. So for me, I do think that it is a horrible experience that we have been through in this last year. And one of the benefits is that we have a lot of people who really had nothing to do with long-term care start to pay attention to long-term care. And now we have an opportunity for those of us who have been supporting this sector in various roles over the years to finally move in the direction that we need to advance what is needed for our seniors across Canada. Thanks, Terry.
Well, thanks, Joanne. And one person that really leaned into this in terms of leadership, Debra Hauptman. Debra, go ahead.
Oh, thank you, Terry, and thanks for the opportunity to participate on this panel. And yes, Joanne, when you mentioned those words about leaning in and the leadership, that's one part I wasn't going to speak to because it makes me kind of choked up. And I have told the story, though, many times of what it was like to see our staff coming down off the home areas at the end of their shifts and the exhaustion, but the determination. And it made me very grateful to work with the team that we have here. In April 29th, 2020, Langley Lodge was declared in an outbreak. The index case was a positive staff member, and within days, the outbreak spread to the residents. And then it spread rapidly through 2 units in our home. In total, there were 51 resident cases and 15 staff cases. It was the worst experience in the long history of Langley Lodge, and one that certainly challenged my leadership and everyone on my team. We believed we were prepared. Langley Lodge is an accredited organization. We're very proud of that. We do a lot of work to ensure that we meet and surpass national standards for long-term care. Our site is built to single occupancy standards, and we've had very few flu outbreaks in recent years. We had a formal COVID-19 preparedness plan. All of the protocols were in place ahead of the orders. We implemented single site orders and visitor restrictions before that was we were called upon to do that in the middle of March. And we were preparing our staff teams. You know, what would you do if we had an outbreak here? Will you come to work? Do you have other concerns? Are you worried about your families? What can we do to support you? Because we know that we are going to be taxed here if we have an outbreak, and we are going to need, you know, all hands on deck. But what we didn't predict was how rapidly COVID would spread, nor how vulnerable our frail elderly are in terms of their ability to defend themselves from this virus, nor the drop in staffing levels, which was dramatic in our case and something we'd never experienced in the history of this organization. We didn't anticipate the struggles we'd have obtaining adequate PPE, and we certainly knew nothing about asymptomatic transmission at that stage in April last year. And those were obviously contributing to the spread in our home. At the end, we had lost 26 residents, and we were a focus of negative and relentless media attention throughout the duration of our outbreak. Our outbreak was declared over on July 3rd after 10 weeks. In the aftermath of our outbreak, I went away for a short break and wrote a report describing our experience, the factors that contributed to the lengthy outbreak, the number of deaths, and the recommendations that I hoped would help prevent other homes from going through what we went through. I have continued to raise questions ever since that time and share my report with decision makers and push for measures to prevent the reoccurrence of COVID, such as rapid testing. Unfortunately, we've had the second and now the third wave, and many of the experiences that we had here in Langley Lodge have been repeated at other care homes, which is really is saddening for me and for my team. I know that we'll be discussing contributing factors and recommendations during this discussion, so I'll leave my comments there for now so we can get on to questions. And thank you for the opportunity.
Thank you, Debra, and thanks for those remarks from our panelists. The way this is going to work, we're going to have a question for each of our panelists, then we're going to have questions that each panelist can answer. That'll take us to about 1:30 or so, and then we invite the audience to submit questions through Slido, and it's hashtag BCCPA. So we'll hopefully get some questions from the audience, and then we'll wrap up by 1:45. So let's start with you, Bob. Ontario, terrific or horrific, I should say, a terrible situation in the first wave. The Toronto Star did a number of stories, but particularly blamed for-profit care providers as, you know, a big contributing factor, even though in Quebec, of course, terrible situation with hardly any for-profit providers. You produced a report. Tell us what you feel were the contributing factors and the role of the ownership model, if any, in terms of the pandemic.
Thanks, Terry. You know, there have already been several reviews in Ontario. There have been several academic public investigations and publications in the CMHA and JAMA related to causal features that contributed especially to mortality and to spread within homes. Not so much spread or disease getting into homes. I think it's pretty clear that prevalence in the community was the cause for infections starting in the home with, generally speaking, well-meaning staff workers bringing infection in from often crowded communities where they lived into long-term care homes. But the contribution, the factors that contributed to spread within homes and mortality have been really studied quite well already. The Morocco Commission in Ontario, chaired by Judge Morocco, that looked at causal factors, commission work by the Canadian Institute of Healthcare Information. Nathan Stahl at Mount Sinai Hospital has published on this. We did work with Revera, a volunteer advisory committee that Revera engaged looking at factors in wave one that contributed wave one. And by far the most important factor we found, Stahl found, Kai found, related to mortality and disease spread within a residence was the presence of overcrowding. And during wave one, there were plenty of homes in Ontario, as mentioned earlier, 32,000 beds within homes that were built in the 70s, 80s, and 90s that had 3 or 4 residents living in the same bedroom. No surprise that once one of those residents was infected, disease would spread rapidly within that community. The other problem with these older homes is they're crowded. They don't have extra spaces, so the potential to actually isolate infected patients when so many people were being affected at once, staff were just overwhelmed with trying to isolate people. It just was physically impossible. And of course, the ministry and public health officials were discouraging long-term care homes from transferring people to hospitals. When we look at the impact of private ownership models, there are 3 ownership models in Ontario. There are for-profit organizations, both national organizations, and in some cases international organizations, and smaller organizations that might own 3, 4, 10 homes. There are not-for-profit community, social organizations, religious organizations.
Looks like Bob is having some internet issues. Oh, we're back. Go ahead, Bob. You froze up a little bit there.
Thank you. So I was explaining the 3 ownership models in Ontario, Terry, of municipal homes. Small minority, about 14% of our homes are municipal, required by the Municipal Act that each municipality provides so-called home for the aged, as they used to be called. And a majority of homes, about 56%, are in for-profit care. Most of those are older homes. The owners, those multinational, in some cases national corporations, have been applying for redevelopment grants from the government. The redevelopment program has been extremely slow in Ontario. It was slow when I was deputy minister. It continues to be slow. And when we look at the factors that were causally related or correlated with outbreaks, no question, it was older homes. Secondary feature was that most of those older homes were owned by for-profit organizations. So I think there have been multiple studies that have demonstrated the key factor was multi-residential rooms, and it so happens that it's been for-profit facilities that own most of those multi-residential units. So that correlation was also there.
Thanks, Bob. Joanne, Vancouver Coastal has looked at the attributes of homes that had outbreaks of COVID-19. How has that learning helped you in changing the way you approached COVID-19 in long-term care?
Yeah, so it's interesting listening to Dr. Bell speak about the environmental factors. Certainly in the very beginning of the pandemic, we wanted to know, and we wanted to know very quickly, what were those attributes. And so we had taken the first dozen long-term care homes and really tore it apart just from a data perspective to see, are there any features of these homes that would be able to use in a predictive way to set up, our resources and our support going forward. But we looked at everything that we thought, and we threw different types of theories at it. Is HPRD, an hours per resident day, higher staffing level? Is that something that makes a home more prone or less prone to outbreaks? We did look at ownership type as well. And we did not find really anything that COVID was particular about. So we reshifted, well, let's look at the different characteristics in our homes to better understand why some outbreaks were larger, some outbreaks were quite significantly smaller. And there were two studies that the teams at Vancouver Coastal Health, we had medical residents, our medical health officers, as well as public health, put these articles together. And there's one great one by Brandon Yao, and he did a qualitative study. And what I love about this one is he actually went back into the homes to talk to not just the administrators and directors of care and the leadership, but to talk to the nurses and the care aides and their experiences. And interestingly enough, after 23 interviews, there were some fairly common themes that were identified that needed to be put in place, and that actually started to inform how we set up our support and resources for wave 2. And probably the biggest is that culture of early identification of cases. So homes that had a very, very, very low threshold for any symptom that either their staff or their resident, and symptoms in terms of just knowing what was normal for COVID symptoms, and then recognizing in a population with dementia other types of symptoms that may go unnoticed. And so homes, in other words, that you sneeze and you get a Q-tip up the nose, it was the culture of we didn't hesitate. We instantly put people on contact and droplet precautions. We automatically got that swab down. We put all the precautions in place. Those homes tended to have a better opportunity of containing and not spreading the virus throughout the homes. In terms of staffing levels, one of the things that we also saw was the ability to cohort. And I know our levels of staffing, our support services, especially when we look at housekeepers and food services, those homes who were able, for the most part, to keep the same group of staff in a neighborhood or in an area within that care home had yielded far greater success than those who were really struggling with staff who were working in between multiple areas and possibly increasing the risk of transmission. The education and training in terms of what went right and what went wrong, we learned that there was an opportunity for night staff, and certainly those homes who dedicated making sure that every single staff understood what COVID was, proper PPE, donning, doffing, accessibility to PPE. Some homes would have it in their possession, but sometimes it was locked away in a cabinet and the person was only going to come on to shift at 7 o'clock in the morning. So just breaking those down in these studies really set up, what were those factors that set apart some homes from being able to turn around. What they saw was interventions in place once COVID was in the home. It was 14 days as a tipping point when the number of cases took a dramatically sharp turn down. And the ability for the home to have that culture, the role modeling of leaders, the communication processes between staff, between leaders and families, and of course with the residents as well. So we learned all of these things, and that really informed, where we spent our fall. And as much as our care homes, wanted help, it was again another burden for us to come into the care homes and ensure that all of these processes were up to par. And, in our exhausted and tired states, I think everyone was trying to do their best. And it's exhausting to maintain a bar and, maintain that sprint during a marathon for extended periods of time. And so it really informed how we ensured that those strategies were put in place and were maintained and continue to be maintained even until today.
Thanks, Joanne. Debra, you said you took some time out, you wrote a report, and I remember that time, and you were so transparent and so generous, where some operators might have been defensive, secretive. You were really generous sharing that report. Tell us about the report in terms of the factors you think really impacted the outbreak, and some of the things you hoped other homes would take from that and to prevent outbreaks in their homes.
Sure. I think the thing we were least prepared for was the loss of staff. And we lost all of our casual staff. We totally agree with the single site order. It's just that then in order to cohort your staff, and if you don't have enough staff, then you simply cannot. And so we know that contributed to the ongoing transmission in our home. And that's a really tough place to be in, and we were definitely in that until we were able to get some support with staffing from our health authority. We also knew that we had an index case, and that's a little bit different from some of the other homes. But I think the important point about our situation is the index case. A care staff member worked in the behavior transition neighborhood unit, and that unit presented a really terrific challenge for us to isolate the residents from each other, and so all of the residents in that home area became positive, and the first death that we had was in that home area. We'll talk a little bit more maybe if we have a chance about the challenges with the behavior transition neighborhood. And for people that are not aware what that is, it's folks with advanced dementia and inappropriate social behaviors who simply cannot understand that they have to socially distance, and are very tactile, like to approach people, touch things. It's part of how they absorb their environment. And another thing was we had a real problem getting PPE, and this is really early on, right, in the first wave. And we were very much on our own with that. There wasn't a provincial supply, as we all know. And so we were sourcing from everywhere. And we do have a contract with a group purchasing company, but every distributor was stretched. And so we were literally running around, going to hardware stores for eye goggles. We were purchasing hand sanitizer from local breweries, face shields from, printing companies here that had converted or pivoted their manufacturing, and from SafeCare for supplies that they could donate to us. So, what we were doing right away was, isolating the affected units. We had 2 units in our care home, and so they became the COVID areas, and we were able to contain it to those 2 areas. And we started mass testing 7 days after the outbreak, but that was too late. And so, we've learned that we need to be testing, as Joanne mentioned, early and identifying the asymptomatic positives. Our first mass testing after 7 days identified residents and staff that were asymptomatic. And by then, of course, the transmission is already underway. We did a lot of education on donning and doffing, and I think it brings to light the fact that in long-term care, we're not accustomed to this kind of work where people are, doing their work in full PPE. It's something that we do when we have a flu outbreak, and that may not happen for, in our case, several years. So, that was an area that we have learned from that, and we know what we need to do going forward. So, some of the other lessons, getting expert guidance at the beginning from the infection prevention and control specialists would have been helpful. I think we were dealing with, the frontline staff in the health authority. There wasn't really, a focus on, where is the infection coming from. They were looking at, at what we were doing day to day here, not maybe looking at bigger picture like the mass testing, for example, which would have been really helpful. And of course, getting the extra staffing so that we could cohort effectively. And I think, we still haven't determined a pathway for managing COVID outbreaks on a behavioral support transition neighborhood. And we have done some work with our health authority on that. I think there's still a lot of unanswered questions there with the right way to go forward with that. I think I've answered your questions, Terry.
Thanks, Debra. That was great. But several of you have mentioned health human resources. So let's talk about this challenge that we've all known about for so long and how it impacted COVID. I mean, there were homes, Bob, in Ontario and Quebec where, with the Red Cross or the Army went in, they found, 3 staff looking after 115 people because everyone was sick or afraid to come to work. Just on a day-to-day basis, pre-COVID, it's really tough for people to have enough time because we just cannot find all the staff we need. How do you think we should address the health human resource challenges in front of us? And then welcome Joanne and Debra to comment as well.
Terry, let me start off by mentioning the continuing care aspect of caring for frail seniors, people with cognitive decline. It needs obviously to start in the community. And the worker who we rely on so heavily for both home care, continuing care, care and long-term care is, of course, the personal support worker. And that role is not one that has been terribly valued in the Canadian healthcare industry. People who are working as personal support workers are often new Canadians. They often come from racialized communities. And the amount they make is in Ontario certainly is highly heterogeneous, whether they're working in long-term care, they're working in retirement, they're working in long-term care, they're working in the hospital. There can be a $6 to $8 variability in essentially doing the same work. So we haven't planned to respect people providing personal support. We haven't looked at a career trajectory that gives them the opportunity for advancement. We haven't looked at the education in infection prevention and control that is necessary in caring for seniors in congregate settings. And we haven't looked at workload issues. In Ontario, the government has accepted the concept of heading toward 4 hours of daily care per resident, probably about 3.2 to 3.4 hours per resident currently. Clearly, we need an investment in education. We need an investment in careerism within personal support. And we need to understand that this is a valued part of the healthcare system. We've spent a lot of time talking about healthcare heroes, and we can't let that concept of recognizing the commitment of people who went into homes knowing that their lives were literally at risk. We have to recognize the dedication and commitment that people working in long-term care have, but we have to equal that recognition with an investment in their careers and an investment in appreciation of the work they do, whether it's in home care, whether it's in long-term care. So better training, better recognition in terms of the value, better recognition in terms of compensation, and certainly a look at how their careers can evolve working in long-term care. Some of the elements that I think are essential to making this a more desirable part of working in the Canadian healthcare system for personal support workers.
Thanks, Bob. Debra, Joanne, any thoughts? Health human resources?
I just wanted to echo what Dr. Bell was saying in terms of recognizing the staff. And I have to say, I was there in our BC's largest outbreak and spent several weeks there and saw firsthand just the commitment that our staff have in showing up in the most precarious situations I have ever seen. And I agree that we need not only to be able to compensate our staff who are sacrificing a lot, who after working double shifts were stepping on a bus to go home with smiles on their faces and still eager to come back to work the next day. It absolutely dumbfounded me how they could even be functioning, and yet they were so committed. So for me, it's how do we ensure that staff are in jobs where we're not adding more responsibility with an increase in pay, and we're not telling them how they need to do their work. I think with a little bit of rules around that, a little bit of regulation, I think we empower our staff and our ability to empower them. And certainly what I saw in the middle of an outbreak was when we empowered our staff They actually made incredible decisions together and on behalf of the residents, and it is what got us through our largest outbreak.
Thanks, Joanne. And if I could, Deb, before you jump in on that, I just want to inject this thought that came up with our conversation with Andre Picard this morning, and that is about regulation, because there's going to be a temptation to put in more regulations. And his criticism, and I would echo that, is that we shouldn't have just a box checking exercise. Empowering people that know what they're doing and looking at outcomes seems to be a better way of approaching this. Debra, what do you say about regulations, and what do you think we should do in terms of ensuring great care without going through a huge bureaucratic overload on the system?
I really think that we're regulated to death and that we have enough regulation. And then we also have accreditation, which I highly recommend and think that, that is very credible work that organizations can do to prepare themselves to provide, the best quality of care. And, I'm pleased that at a federal level where there is a process now in place to review long-term care standards, and perhaps that's the way to go, because that's more of a learning and quality improvement kind of direction rather than, regulations, which, often don't really address the issues. And I think if they did, we maybe wouldn't have had the severity in the outbreaks that we've had. We certainly were investigated, by every authority in the land and every corner of our home, and nobody found anything that was remarkable, that would have, changed the picture other than what we already knew. And I just want to comment quickly on the health human resources side that we have some rebuilding to do because long-term care has been painted in such a negative light. And for young people that are considering career options, I'm not sure that long-term care is jumping out at them after, the type of messaging that we've heard. So we really have to, get back to what the values are here in the organizations that we work in, and how rewarding this career is. And I feel fortunate for every day that I come to work. I don't know where you can get a job like this. And, besides having a really bad year, and you told me I couldn't swear, so I won't say any bad words, but the worst year ever, I wouldn't choose any other career over this. So we have to do a better job of marketing. And we also, lastly, the direct care hours have to be bumped up, and that's better care for residents, but it's better support for the staff because they're really working beyond their capabilities most days of the week.
Thanks, Debra. Bob, your thoughts on regulation?
Well, I'm going to turn the table a little bit here and talk about inspection. I agree with Deb and Joanne that certainly long-term care is heavily regulated. Let's face it, we have extremely vulnerable people. It makes sense that there's a lot of regulation. I don't think more regulation is needed, but are patients actually being cared for appropriately under those regulations? Are the regulations that are important being observed and respected? One of the features in Ontario was that inspections had dramatically reduced prior to the pandemic beginning. A program of regular inspections for all long-term care homes had been dramatically reduced. And I think the concept, especially of outcome-based inspections where outcomes in residents are evaluated by trained inspectors, is an important part of caring for vulnerable people in settings which are and can be somewhat isolated. That's one thing that was recognized during the pandemic, was how isolated long-term care homes are generally from the healthcare environment in Ontario, certainly. And because of our focus on the acute care setting, we made those long-term care residents even more isolated. So the concept of having more IPAC training and having integration of hospital settings, hospital staff, physician staff especially, one of the features that was determined by CI to have an impact on the risk of outbreaks in a home was whether or not there were any physicians actually present, not virtually, but physically present in homes. The concept of linking our medical systems to long-term care more thoroughly, as well as inspecting those settings for adherence to regulation, I think are a couple of things we should be thinking about going forward.
Thanks, Bob. And that brings me to a question from our audience about the system. So I'll start with you, Joanne. We saw in the EY report, the report that we did, that there's some miscommunication, inconsistencies among regional health authorities. Bob looked after a system that had not just 5 regional health authorities, he had probably 10 times that many different local authorities. What are your thoughts about the integration of the system and you know, did our sort of more integrated system here in BC help? And is there more we can do to have a better integrated system?
Yeah, so I think when we talk about integration, so much of it boils down to where decisions are made and communication. And so much of what we saw was where areas truly worked as silos and weren't connected in with other parts of a healthcare system struggled more. And I think there was certainly benefits. Our health authority approach enabled us to look at the population of who we were serving within our geography. We were able to look at those who were in long-term care, assisted living, and are independent, but also those who were at home, and look at the truly vulnerable in our society. And even though we're talking about long-term care, I can't, forget to acknowledge that there were far more people in the trenches, in the shadows, who we really were challenged to try and find better ways to support them through this pandemic. The isolation, the exacerbation of mental health and addictions, the opioid crisis that was already there and continues to plague us. So for me, the integration, certainly from a structural point, our health authority, I think, stands in a better position in our province by having the mechanisms, how the ministries are structured and how they function, the commitment to work with industry associations at a provincial level and having tables where there's direct communication between industry associations, health authorities, as well as our various ministries, I think put us in a bit of a better position. For us, I think where we go is looking at seniors' care outside of just a silo of long-term care or assisted living or independent living. If we can truly get to the point and place where we are reimagining and looking ahead as to the needs and what is the population that is going to need long-term care versus the populations that we are going to be pushed to find more creative solutions and options to keep people at home in unprecedented ways that we can't even imagine right now. I think that is going to come from an integrated system that's looking at the person despite the various structures and infrastructures we have around them.
Thanks, Joanne. Debra, you mentioned testing, and that's probably something that the Seniors Advocate is going to be looking at, Isabel McKenzie, with whom you shared your report. What do you hope that comes out of Isabel's review for Bob's background? Our Seniors Advocate is currently conducting a review that hopefully we'll have by the end of July. So Debra, what do you hope to get out of that? And will it be sufficient, or do we need a more sort of thorough, independent public inquiry, much like the commission held in Ontario?
Well, the Seniors Advocate's approach is to compare homes that had, outbreaks that spread to a very large outbreak with those that had of a similar size that had outbreaks that did not spread or were contained, and to see if there were any differences there that we can glean from and perhaps take forward into planning going forward. I personally, I'm curious about that, and of course, we're going to be one of the homes that are included as a home with a major outbreak. But I would like to see an independent review of the systems that supported long-term care. And I think it's necessary. I feel as an operator that there has been a lot of focus, kind of drilled down in the weeds, kind of focus on long-term care. But there were a lot of things at much higher levels that were outside of our realm of authority and our realm of control that really played into this. And we've spoken of a number of them already in this hour. So, Ontario has commissioned their study, and there's the Royal Society report. I think that BC should have an independent review and look at this overall. And the goal should be not to point fingers, but to come out with a clear set of recommendations that can be incorporated into provincial planning at a provincial level. And I think experiencing an outbreak and dealing with a health authority that's trying to get answers from provincial level, and things filtering down, and time that you're waiting for answers on things, when things should just protocols and preparation and PPE access, even simple things like that, should be at a provincial level and accessible to everyone in the province.
Debra. I'm going to throw this one out there. I hope it doesn't catch you off guard, Bob, because I'm going to pose it to you initially. And that is we're hearing a lot about aerosol transmission. At first, it seemed we were a bit obsessed with contact and fomites to the point where Christmas decorations were being taken out of rooms. Why were we so slow to understand the aerosolized transmission of the virus, and what does it mean going forward in terms of design of long-term care homes?
Well, I think it's pretty clear that airborne transmission is part of the reality of SARS-CoV-2. And I think it's on a continuum, Terry. I think most respiratory infections have an element of aerosol transmission with viral particles, small, less than 5 micron particles, suspended in the air for periods of time. Part of this, I think, is managerial in the healthcare system, in that, especially at the start, we didn't have enough N95 masks to actually protect workers in hospital who are caring for desperately ill COVID patients. Therefore, it was hard to say, gee whiz, if this is an airborne contagion, should our workers in long-term care all be wearing N95 respirators? So I think that was part of the slow recognition of aerosolization. I think the other thing is we need to pay attention to the spending that's needed in long-term care. We need to spend money keeping people out of long-term care, but when we bring vulnerable seniors into long-term care, we need to think not only about the fact they need to have private rooms, they also need to have adequately ventilated facilities with air exchanges that are similar to what we find in hospitals, 6 changes per hour, to the potential for filtration of that air. And these are changes that are expensive and require a rebuilding of our long-term care environment, not just for this pandemic, but let's face it, for future respiratory pandemics that can occur, or even for flu outbreaks that we face on a regular basis in long-term care that we're used to. We need to pay attention not only to the spacing and the amount of space per resident available in long-term care, we also need to think of the quality.
Thanks, Bob. We need to also do something about the quality of broadband in Ontario, I guess, because you froze up for a second again there, but I think we captured most of your comments. Joanne, briefly, because we don't have a lot of time left before closing remarks, but I wanted to pose to you the idea of testing, and do you foresee a future where point of care testing for COVID, for RSV, for influenza just become normalized in long-term care?
Good question. Thanks for posing an easy one at the end of this discussion. I certainly see a level of screening that will be required. What it looks like in terms of that point of care testing versus someone who is, asking questions, still to be determined. But for this little while longer, I anticipate that we're going to need some kind of screening, something that is a little bit more sophisticated than someone standing and asking questions. And I do think that it's with that hypervigilance, we're sitting here 4 months without any outbreaks in our health authority, and we've just had our first one in the last 4 months. And for us, we can't let our guard down. It's still too early days. So the measures, the tools that we have right now that are available to us, we need to keep using until something else gets developed and informs a way forward.
Well, listen, you guys, we could spend all afternoon. This has just been a tremendous discussion. I really wish we had more time, but I'd like you to just close with some comments, what you'd like the audience to take away from our discussion today, and then I'll come back with a couple of closing remarks. So Bob, we'll start with you, then Joanne, then over to Debra.
Terry, to me, the defining feature of the sustainability of our Canadian publicly funded health system will be determined by how we care for seniors. In Ontario, people over the age of 75 are increasing by 4% per year. That is an extraordinary number. Right now, we need to rebuild of the 78,000 long-term care spaces. We need to add spaces and rebuild 70,000 spaces. That's probably going to approach $30 billion of capital. So this is a challenge. I think it's a challenge that, as I say, will determine whether or not our publicly funded system can survive and provide all kinds of care that we need to provide in the face of the boomers who've always defined everything for the last 50 years. The boomers are getting older, and we simply need to figure out how to deal with them effectively, compassionately, but also in a cost-effective way.
And Joanne is the only non-boomer on the panel. Your closing remarks.
I think I have some job security. I think that when I look at the last year, Vancouver Coastal certainly has seen over 55 outbreaks, and we've seen over 250 residents who have passed away in this last year from COVID. And while absolutely there will be reports and our focus needs to be on quality of life, I hope that we don't lose not just the number of people who have passed away, but how they died, and learn from the experience of not being able to see the smile on the face of their staff because they had to be wearing masks, or the touch of a human hand because it was gloved, or even visit a fellow neighbor resident and not allowed because they're on contact and droplet precautions. And I think we can't lose the quality of death and how people died. It does make me think about, our recent news here in BC with our 215 children who have now been discovered in Kamloops in the residential school. And there's an equal commitment to look at the circumstances surrounding deaths that I think will propel us into the future that we cannot lose through this as well.
Over to you, Deb.
In our experience, I think that the people that were not considered during the massive struggle to get on top of COVID were the elders in our care, and we found that was often not in any of the conversations. It was really about infection prevention and control, which we all understood and all definitely wanted to participate in to ensure that we got our COVID outbreaks under control. Going forward, we have a very frail population in long-term care. I'm not sure that the public understands the frailty among the residents that we support here, and the impact on them of the measures that we put in place. So I think that we have to find that balance going forward of how we protect the elders, as well as how we respect their need to have some quality of life even during a pandemic.
Well, thanks, Deb, and thank you all for a really great discussion, Dr. Bob Bell, Joanne Tait, Debra Hauptman. It's been fantastic, and thank you for each of your commitment to seniors care, whether here in BC or Bob in Ontario. Your words today will help us get better in terms of looking after our elders. So thank you all for that, and I'd like to thank our sponsors for today's session, Extendicare and SGP Purchasing. Before we conclude, I want to remind viewers that tomorrow's conference will start at 8:45 with some opening remarks. And then our key panel at 9 a.m. is entitled Mind Over Matter, Addressing Worker Mental Health and Resilience Through COVID-19. You'll really want to take in that panel, moderated by Jen Lyle from Safe Care BC. So we'll hope that you'll join us for that. It's been a great first day of BC Care Providers 2021. We hope you will join us tomorrow and again on Wednesday as we tomorrow look back at we look at resilience, and then on Wednesday we look at reinvention and how we can all help to make our system better than it is today. Thanks so much for joining us.